Okay, I just want to say thank you all for coming in this nasty weather. My name is Karen Barnes. I am a registered pharmacist and I am a PharmD candidate at the University of Colorado. Today I will be presenting on Afrezza, a needle-free insulin for better glycemic control. I ask that you save all your questions at the end of the presentation. Before we get started, next, I would like you to keep Miss BB in mind. Miss BB is a 45-year-old obese female. She has no known drug allergy. She is a non-smoker. She has no, she is not a, she is not asthmatic. She does not have COPD, and she does not have lung cancer. Her health conditions are she has been a type 2 diabetic for 10 years, and she is currently on glimepiride 4 milligrams and metformin ER 500 milligrams. For her hypertension, she is taking lisinopril 40 milligrams, and for her cholesterol, she is taking atorvastatin 80 milligrams. And for heart protection, she is taking aspirin 81 milligrams daily. Other significant history about Miss BB is that her A1C has been 8% for 6 months now. Her postprandial glucose levels have been over 180. It was suggested that she try Lantus, a 24-hour insulin. However, Miss BB refuses due to her fear of needles. The question I would like you to think about is Miss BB a candidate for Afrezza, and why? And what outcomes, positive outcomes, will she experience from using Afrezza? To get started, are your patients tired of giving themselves insulin injections? Are they taking more insulin-free days due to needle irritations? Or is it the lack of privacy and time to administer insulin due to inconvenience? Are they having difficulty managing their A1C? Well, today we are going to talk about Afrezza, a newly inhaled insulin delivery system. Afrezza may serve as an alternative to insulin injections for the diabetic community. This 45-minute presentation will show how Afrezza can help diabetics achieve better glycemic control and slow the progression of associated complications. At the end of this presentation, one will be able to describe Afrezza's mechanism of action, compare and differentiate between the inhaled and injectable insulin's time of onset, recite the findings of the Affinity trial on Afrezza's impact to lower A1C in insulin-naive subjects with type 2 diabetes, its safety and efficacy, identify chief adverse effects associated with Afrezza, identify those subgroups of people that can and may not benefit from inhaled therapy, and recall and be familiar with packaging, available strengths, and storage. Now, one might say, what is Afrezza? Afrezza is an inhaled insulin delivery system to help manage high blood sugars and help lower A1C. It is a rapid-acting, recombinant human insulin approved by the FDA in June of 2014, and manufactured by MannKind Corporation. Afrezza technology involves the conversion of recombinant human insulin to a powder. Under acidic conditions, fumarate deketoperazine, an excipient, is crystallized to 2.3 nanometer microparticles. The powder insulin is then absorbed onto the particles for deeper lung penetration. At this time, it is called Technosphere insulin. A Gen 2 power inhaler device is used for Technosphere insulin delivery. The mechanism of action is that the insulin stimulates the peripheral glucose uptake into the cells by skeletal muscle and fat, inhibiting hepatic glucose production. The microparticles are absorbed through the alveoli of the lungs and lung lining fluid. Then it goes into the bloodstream with no effect to cell viability or plasma membrane integrity. The serum concentration is reached in 15 minutes, peaking at 40 to 60 minutes with a duration of 2 to 3 hours. The excipient is then released from the insulin and excreted through the kidneys with no effects to the body. Its rapid effects compared that of Apidra, Humalog, and Novolog. However, their duration of action can range up to 4.5 hours, prolonging the postprandial glucose levels. Now this this slide is sort of dark. I don't know if you can see it, but this is where Apidra, Humalog, and Novolog peaks at 15 minutes and comes down approximately here at 3 hours. And then you can see the Lantus, which is a 24-hour insulin, and it pretty much is steady state. Let's go to the next slide. For people who are visually challenged, here's a better picture of where Afrezza will align up here with the Apidra, Novolog, and Humalog. Okay. Now we're going to transition into the clinical trial, which is the Affinity 2. That trial was headed by Rosenstock, Franco, Kopacek, and other authors. The citation was titled Inhaled Technosphere Insulin versus Inhaled Technosphere Placebo in insulin-naive subjects with type 2 diabetes inadequately controlled on oral anti-diabetic agents. And here I listed the website if anyone would like to read further on about the study. The goal of the study was to assess the efficacy and safety of Technosphere insulin and Technosphere placebo in conjunction with oral anti-diabetic agents of insulin-naive type 2 patients. It was a 24-week study, and it ran from November 2011 to June 2013. It was an international phase 3 study which focused on efficacy and safety. Multi-centers were located in the U.S., Brazil, Russia, and the Ukraine. It was randomized, double-blinded, and placebo-controlled. In the inclusion process, you had to be 18 years of older with uncontrolled diabetes. You had to be on metformin only or metformin in conjunction with a sulfonylurea or a dipeptidyl dipeptase 4 inhibitor, which included Onglyza or Januvia. You also could be on other combinations without the metformin. You had to be a non-smoker for 6 months or more, and your forced expiratory volume in 1 second and forced vital capacity had to be greater than 70%. For exclusions, if you were on a glucagon-like peptide 1 agonist, that would be like Byetta and Victoza, Trulicity, or a thiazolidine diones. In 3 months of the study, you were excluded, as well as being on weight loss products or having 2 or more unexplained hypoglycemic events. If you had hospitalization or ER visit in 6 months, you could not participate in the study. Any severe diabetic complications or severe pulmonary conditions, or if you were pregnant or any hypersensitivity to the insulin, you were excluded. It was, like I said, a 24-week study. The first 6 weeks was a run-in study where in those 6 weeks, the patients were introduced to monitoring their sugars. They also were introduced to diabetic management in terms of physical activity, nutrition, and just learning about the diabetes itself. They were introduced to using 10 and 20 unit cartridges of Afrezza, which is equivalent to 4 to 8 units of subcutaneous insulin. Okay, it was randomized, and during the 12 weeks, which the 6 weeks is part of it, they went through titrations based on their glucose readings. If anyone needed extra insulin, they were granted the extra insulin. They also wanted their postprandial glucose levels to be at 110 and 160. If it was over 180, they got extra insulin. During the final 12 weeks, their A1C should have been stabilized. The only way they would give more insulin or change the dose if it was in emergency type situations, if your glucose was too high. At the end of the 24 weeks, they tacked on another 4 weeks for additional observation. They, for the primary efficacy measures, they looked at the mean change of A1C from baseline to week 24. The secondary efficacy measure looked at the 7-point plasma glucose profile from subjects' glucose readings. And these readings or recordings included blood sugars before meals, blood sugars 90 minutes after the meal and at bedtime. They looked at subjects reaching their A1C at 7% and 6.5% at week 24, changes in their fasting prandial glucose levels, their body weight from baseline to week 24, and subjects reaching rescue therapy. For the safety assessment measures, they looked at adverse events, 12-lead electrocardiograms, vital signs, clinical lab values, physical examinations, hypoglycemic events, pulmonary function, and spirometry. In the statistical analysis, they looked at mixed models, repeated measures, and that took into account A1C's term of regions. In term of regions, other anti-diabetic drugs, visits, treatments, and interactions of treatments by visit. They looked at the FEV, which was the forced expiratory volume, evaluations of the fasting postgranule, no, that's not even right, excuse me, over study period. They looked at autoregressive first order covariance structure, which looked at repeated A1Cs and FEV measurements. They looked at the Kaplan-Meier estimator and log rank, which looked at subjects receiving rescue therapy and comparing the groups in time to rescue. They also used logistic regression analysis, looking at those subjects that reached A1C of 6.5 and 7.0%. When we look at the demographics and baseline characteristics, in the insulin group, there were 171 participants, and in the placebos group, 176. As you can see, the age was around 56. The BMI, body mass index, was 32 kilograms per meter squared. Female participants ranged around 54%, and the placebo was 58. The diabetic years was 9 years for both categories. The baseline A1C was 8.2%. Metformin alone was 24%. Most of them were in the combination with metformin and some other anti-diabetic agent was 65%, and 11% of other combinations. At the end of the week, the 24-week, Technosphere insulin group had 150 participants that finished out the study, and the placebo group had 139. Next. For the outcomes, the primary efficacy measures, we see that there was a great reduction in the A1C by a difference of 0.4% for the insulin group compared to the placebo group. There was improvement seen in the second week of lowering of the A1C. There was continual improvement until the 12th week where the A1C stabilized. Now when we look at this chart here, that first week everyone started at 35 units with a plus or minus of 14 or 10 units less or more. In the 12th week during the titration, you see that the insulin requirement increased. The insulin group was 109 and the placebo group was 164. But you also see that there's a 30 unit difference here where it was plus or minus 58 and plus or minus 84 for the placebo group. And then during the last 12 weeks, there was just a slight increase for the insulin group, but a greater jump here for the placebo group. So the supplemental dose averaged a 35% increase compared to the placebo group, which was much more of 45%. When we look at the secondary efficacy measures, there was a reduction in post-meal glucose values in the Technosphere insulin group. There was continual improvement for the A1C from the 12th to the 24th week. And the insulin group had a 0.82% versus a 0.42. That's where there was a difference of 0.4% difference over for the Technosphere insulin group. For the A1C targets, for the insulin group, 38% reached A1C of 7%, whereas the placebo group here reached only 19. Those subjects reaching 6.5, it was 16% in the insulin group and 4% for the placebo group. The Technosphere insulin group received less rescue therapy. Now there was a slight weight gain for the insulin group of 0.05 kilograms versus a weight loss for the placebo group. 61% in the insulin group experienced adverse effects, whereas only 51% of the placebo group experienced adverse effects. Coughing was the chief main effect. It was 24% in the insulin group and only 19% in the placebo group. There were no serious respiratory adverse effects, and discontinuation of the study was only due to personal reasons or social reasons. Continuing on with the secondary efficacy measures, the baseline FEV was normal between both groups. However, there was a small decline in pulmonary function. Hypoglycemia was greater in the insulin group, which was 67.8% compared to 30% for the placebo group. Now, rescue therapy ranged at 9.7, but that was not significant compared to the placebo group. Post hoc exploratory analysis was done looking at the anti-diabetic agents and event rates because they thought this would and may have contributed to more hypoglycemic events in the TI group, which is the insulin group, because remember, they're on anti-diabetic agents. There were no deaths. Now, 4 weeks after the program, postprandial glucose values were similar to the Technosphere placebo group. When you look at this diagram here, this, at the 12th week, the placebo group postprandial glucose values are high, but here, the black line, this is your insulin group, and their postprandial glucose levels are pretty good. Now, when you change to the next slide here, at week 28, that's their 4-week observation, their postprandial glucose levels came right back up. So you know, when you're not being watched, you go back to your old ways, and there we go. Next. So the author says, well, we have seen significant A1C reductions by zero point 0.8 in the insulin group, and that's from their baseline. There was a decrease in postprandial glucose levels, and okay, cough was transient but not bothersome. Is the cough due to the excipient or the dry powder? Other factors that may have enhanced A1C reduction could have been the addition of other anti-diabetic agents, close monitoring of the subjects, medical supervision, or patient education on diabetes management. Also, the limitations of the trial, there was an absence of a comparator, needs for a more standardized regimen on the insulin, and it was also funded by MannKind Corporation. Afrezza is the only inhaled insulin on the market. It has proven to be safe and efficacious in lowering high blood sugars and lowering A1C. Afrezza is very well tolerated and serves as an option to injectable insulin. Because of its newness, we have a lot to learn from Afrezza's benefits and risks and long-term safety profile. Now we are going to switch gears and look at the clinical side of things. As healthcare professionals, we are constantly asking ourselves, what is the best therapy for my patient? Will this particular medication achieve the therapeutic response I am looking for? How will my patient comorbidities and current medications interact with Afrezza? Will my patient be more compliant in the route of administration if it is not painful? As pharmacists, we are more concerned with restoring a patient's well-being. In doing so, we look at dosing and administration, drug interactions, adverse effects, contraindications, and monitoring parameters. When we look at dosing and administration, remember that Afrezza is only for inhalation purposes only. And here is the insulin injection for you to compare to dosing the Afrezza. So let's say you have a patient that's on 9 to 12. They have two options here, to take a 4-unit cartridge and an 8 to make their 12, or just one. But let's say you have a new patient and they never tried it, so you might want to go slow and start low. So you may want them, they might want to try an 8 by itself or a 4, because remember, they are on other anti-diabetic medications, and this is new for them. So we don't want to put them in a hypoglycemic event. Okay, next slide, please. Pharmacologic agents that cause hypoglycemia are other anti-diabetic therapies: angiotensin converting enzyme inhibitors, angiotensin II receptor blockers, fibrates, fluoxetine, and sulfonamide antibiotics. And this is just to name a few. Pharmacologic agents that increase Afrezza's effectiveness are albuterol and epinephrine, antipsychotics, oral contraceptives, corticosteroids, diuretics, isoniazid, phenothiazines, and protease inhibitors. And these are just to name a few. In some cases, your dose may have to be adjusted. Adverse effects: coughing. Coughing was 24% in the insulin group. It could be either dry or productive. You may have a sore or irritated throat, bronchospasm, headache, urinary tract infection, fatigue, nausea, and diarrhea. These are some of the main effects that they experience. Next. Subjects that may and may not be able to benefit from Afrezza. type 2 diabetic uncontrolled can and will benefit from Afrezza, not unless they are hypersensitive to the insulin. A type 1 diabetic can benefit from Afrezza. However, they must have a long-acting insulin on board, such as Lantus. Now, subjects that may not benefit from Afrezza is an asthmatic, chronic lung diseases, or COPD, diabetic ketoacidosis. This is not recommended for them. If you are a smoker, lung cancer, or any hypersensitivity to the insulin. Next. Mindful monitoring is that with pulmonary function, because there is a slight decline, you may want to get a baseline reading for their function, and then at 6 months get another one, and then you can do pulmonary function testing annually. During the study, they found that when they discontinued the Afrezza, their pulmonary came back to normal. You might want to watch out for bronchospasm and check their A1C quarterly, and then when you're comfortable, twice a year. Hypoglycemia, hypokalemia, fluid retention, and heart failure. Importance to the pharmacist that they look at each patient individually, because it will have to be dosed individually. It is not a substitute for a long-acting insulin, and it is not to be used for treatment of diabetic ketoacidosis, and still Afrezza lacks data on long-term safety. Weighing the pros and cons. The benefits of Afrezza is that it is non-invasive. It helps lower the effects of the postprandial glucose. Patient may get better glycemic control. There's a decrease in insulin injections, especially for the type 1 diabetic. Decrease in hypoglycemic events, and better management of their diabetes. Now, we also have to consider cough. Cough doesn't agree with a lot of people, even though after 1 week it sort of like tapers down. But if you have a patient who is constantly having sore throats, irritated throat, you don't want to open them up for infections. The Technosphere issue is that you want to make sure that they have the technique down to inhale all the insulin. If not, they're not going to get the benefits of the insulin. And also, you want somebody who has inhalation power to bring it in. Also, there's a decline in pulmonary function. You want to think about their effects on other comorbidities, and the cost and prior authorization. Just so you know, out-of-pocket cost is like $420. It does require a prior authorization with most insurances. Next. Now, when one gets a prescription for Afrezza, it comes in kits. Each kit contains 2 inhalers and an assortment of doses. As you can see, you have the 4 unit, which is blue. You have the 8 unit, which is green, and the 12 unit, which is yellow. And you only get 2 inhalers, and you have to change it every 15 days. Next. Okay, storage and handling. Afrezza should be refrigerated at 2 to 8 Celsius or 36 to 46 Fahrenheit. If not refrigerated, which your house or room should be at 25 Celsius or 77. If it's not refrigerated, you must use it in 10 days. If it is open, let's say you have a cartridge open, you have to use it in 3 days. You should not be shaking the inhaler. You should hold it upright and level. If you store it in the refrigerator, take it out for a few minutes, 5-10 minutes, let it sit, then use it. Never wash the inhaler. Okay, and that's probably due to safety and infection reasons. And you can use a cloth to wipe the mouth Heath, okay, due to moisture and lipstick. In summary, Afrezza is a rapid-acting insulin which stimulates peripheral glucose uptake into the cells by skeletal muscle and fat, inhibiting hepatic glucose production. Afrezza's particle size of 2.5 nanometers allows the insulin to circulate through the lungs into the bloodstream, achieving a 15-minute onset of action with a duration of 2 to 3 hours. The Affinity 2 trial found Afrezza to be safe and effective as A1C levels gradually decreased within 2 weeks. Although cough was the main adverse effect, it was observed to be transient and reversible when discontinued. Afrezza is not recommended for people with COPD, asthma, smoking, pregnant or lactating or lung cancer. Afrezza is available in kits containing 2 inhalers and an assortment of color-coded doses of 4, 8, and 12 units, which should be stored in the refrigerator or used within 10 days if not refrigerated. Now, let's get back to Miss BB, our type 2 diabetic, whose A1C has been 8% for over 6 months now. Her postprandial glucose levels over 180 milligrams per deciliter, and she refuses to use Lantus because of her fear of needles. So, the question that was presented was, is Ms. BB a candidate for Afrezza and why? And what positive outcomes would Ms. BB experience? Now, before we go to the next slide, would anybody like to share their thoughts on the question?
I think all she had was high blood pressure, she was type 2, and she had high cholesterol, am I correct?
Yes,
That was her only history.
yes, yes.
So, with that in consideration, if she's afraid of needles, yes, I would think she would, because she would have better control of the diabetes. Now, the next question would be, could she afford it? Because I think you said you have to get pre-certified for it, right? And I'm thinking that, when insurance consider, how serious it has to be for that she can actually be certified, pre-certified to get the medication, whether they will authorize it or not. And in the long term, I think you said something about the inhaler had to be changed every 15.
The inhaler piece, yeah.
Has to be changed every 15 days, and you take in consideration, does the medication and the inhaler, does that come together, or is separate, like the needles and the insulin, and changing it every 15 days? I'm just looking at ways as recommended to someone who has limited income and Obamacare and
Okay.
just do that in. But anyway,
Well, those are some good thoughts.
yeah. So I would think she would be a candidate.
Okay.
She's a type 2 diabetes, right?
Yes, she is.
Is she exhausted with other options? I know she's afraid of needles.
Mm-hmm.
And also she is, BMI is very high. She is 32.
Yes.
And the insulin increases the gain weight.
Yes.
Right? And also she cannot use glucagon peptide inhibitor because of the controversy with this drug.
Yes.
So why do we have to go with this drug for her? Since she hasn't exhausted with the other options with type 2 diabetes medicines.
Well,
I was thinking her insurance
Yeah.
may say.
And also
you
it's
need
very
to try
expensive.
these other ones first.
and that's true.
Yeah.
That's true. And they
And
may,
also there are side effects, and also there is a conflict with glucagon, and she's obese, right? She needs to lose weight.
yes,
She's not effort to weight any more weight.
yes. All of those are good options. She does have other options if she is willing to try and follow through on them. Okay? So we shall see what happens here. Well, as you can see, Miss BB is smiling. She is happy. She is a candidate for a Afrezza. Her A1C is high. She has a needle phobia, and she does not have any comorbidities that would interfere with using Afrezza. The positive outcome that she would experience is a lowering of her A1C, a lowering of her postprandial glucose levels. She may be more compliant and have better management over her diabetes. Now, the last thing I'm going to say is Afrezza. Afrezza, is it the answer for your patient? And I say thank you. Thank you for listening.
Oh,
Very good.
So now I open the floor up for any questions. Yes, there are many options that Miss BB could try, but when you think about people and the nature and what they do, and I guess it's hard. They want to keep up those habits that they have been doing, and if you don't have that support system to say, hey, let's go walk, let's change our eating habits, it's hard. We just want to take a pill. We just want to take something that says, hey, I'm going to cure this and I'm going to continue my same habits over here. So when we can bring these things together, we'll be a whole happy human being.
So is Afrezza popular in retail now? I didn't think
It's,
so.
it's new. It's
Right.
new, and it just showed up in our computer because I checked. I even went to the hospital.
It's strange though, it's approved in 2014,
Right.
and now we are in 2017.
It's not.
And
jumped
by the
out
time
at
they get into the market, looks like their patent will expire.
Yeah.
Then they'll be making a generic.
Yeah.
but you said it was approved in 2014, am I correct?
It was
And
what?
It was
Yeah.
approved 2014,
Yeah,
it
June.
just came to your computer.
I think she has it.
Well, that's because I just looked, you know, since I was doing this topic. Who's to say when they put it in there, what's the earliest they put it in there?
I think it would be good for, patients that, not so much fear of needles, but some do not have the inconvenience
Mm-hmm.
of actually taking insulin.
Yeah.
Compared to like the job, how they travel, the cleanliness and things. It is,
Mhm.
it's
And-
something that
Yeah.
most people will probably really like.
They don't
but,
have much.
can they afford it?
Right. I think they'd be more inclined to take it because
Yeah.
they're not worried about people seeing, you gonna stick a needle and somebody look at you.
Right.
They don't want that. They might feel more comfortable doing an inhaler. So,
The one disadvantage with this is it comes in only 4, 8, 12. What if somebody falls in between, or 5 or 6?
well, they can
Hypoglycemia,
try the 4, okay,
And then lower
and see
down.
what happens. I was trying to really look at and find dosing information, but because it's new, I really could not, There was even one suggestion of adding all the daily insulin that you take and divide it in half, and then divide that half into your 3 meals, because they're taking anti-diabetic medications and you want to titrate until they're at a comfortable level. But let's say if they were taking 34, and your highest is 12. So you got, 30, you can go up as high as 36. But then you still have to monitor their hypoglycemia. You don't want them get there,
And
And they might not be able to get away from needles anyway, if after so many weeks, the test group had to insulin anyway, didn't
Yeah,
they?
well, you.
Some of them did.
You had the inhaled insulin, but see, for the placebo, that's what the limitation was. There was no comparator. So what were they inhaling?
Probably.
It didn't tell you.
Yeah. Not the medicine.
Right.
And you said, the people that were on this medication also, the inhale, they were on some type of oral medication
Yeah.
also.
Yeah.
That
They
was
were on
included.
oral.
Right.
Mhm.
So, you know, another concern with mine would be, I guess, the same, you know, because this is rapid acting and,
Right,
you
So-
know, they would have to really be monitored really well.
Yeah, it's
Right.
$400.
Mhm. Yeah. yeah. So it was just that extra help, that boost to bring that A1C down and monitor the A1C. I mean, their blood glucose. Because you know, as diabetics, they'll take their medicine and they'll still go out and eat what the heck they want because they think they covered.
And also what do you call, not predictable, expected, like when you inject insulin, you know how much insulin you are putting in the body.
Mhm.
But when you inhale,
Right.
if somebody has a coughing problem or any lung problem, COPD, or what is the expected values? It's the same.
Well,
whatever the dose.
it's not, but it's not recommended for
No,
people,
not exactly COPD, but no, I think they said.
No.
or even with asthma, because it
Oh, asthma and
can
COPD,
cause
okay.
bronchospasm and
Right.
stuff. Their lungs are already compromised, so really we're talking about healthy lungs here. And they have not really did studies
Yeah.
on asthmatics and COPD patients or like pulmonary fibrosis or that's even the smokers.
Yeah.
So those trials, studies are still pending.
That's probably why it's just hitting the market, because when you factor in, who's not qualified for it, that's like a small
Everybody.
percentage
I'm
that
shocked
could, you
they
could
had about
refer this
400
medicine
people.
to.
They got 177, 176, and I'm thinking, with those parameters, I'm shocked they got that many.
Well, it started out, but you know, with these trials, they weed out
Yeah,
a lot of
yeah.
people.
No, but they also give a lot of incentives
That's true. they
and
probably
free
did.
testing and all those kind
Mhm.
of benefits.
But with coughing as the big side
Yeah.
effect, you would think that, I wonder if any of the medication
Well,
coughed up.
Because it had very high percentage,
well, they,
Yeah,
and also very high percentage cough, and then the hypoglycemia is some 36%.
30
Versus 16, I think, something like that. In people taking this one.
hypoglycemia.
it seems like it's catering to a very small group of people.
Yeah,
Well,
very,
it was
very
done
small.
with a very small group of people.
And push yourself away from the table.
Oh, I better get back.
While you're looking for that, my other question would be, you have to change the inhaler every 15 days. Is there a price on that one also?
Okay.
Plus 400 something plus the inhaler every 15 days, that's a lot of money.
Well, I actually tried to find a, how can I say? It may be like an extra box that could be purchased with inhalers alone. And that's something they may consider in the future because I didn't see anything for that. Because anything can happen with the inhalers, you drop it, fall in the water,
Looks so big.
crack it. So, that's one thing I thought of. Now, getting back with the hypoglycemia, and I said 67%, but that was also why they considered the post hoc exploratory analysis, because these people were also on anti-diabetic medications. So you had that going on too. And another thing, they could have decreased the medications, but that was something that they had to consider. Well,